Diagnosis and management of dyspnea. Dyspnea came from the Latin word dyspnea, and also called as shortness of breath, air hunger, and subjective symptoms of breathlessness, normal in heavy exertion, and pathological if it comes unexpectedly in normal situations. So it's an unpleasant subjective sensation of abnormal respiration, labored breathing, physical presentation of respiratory distress, and there are many causes which we'll be discussing one by one in our presentation. So it could be dyspnea on exertion after eating, nocturnal dyspnea which come at nights when the patient is sleeping, or paroxysmal nocturnal dyspnea which comes and goes, and dyspnea which is seen progressively increasing during pregnancy. The respiratory distress is a vague term meaning non-breathing well. It's a constellation of the signs including using of accessory muscles of respiration, tachypnea, gasping, panting, restlessness, sometimes also confusion of hypoxemia, and somnolence which is seen in hypercarbia. So the respiratory definitions can be altered according to the rate of breathing, and eupnea, bradypnea, and tachypnea. Apnea is not breathing at all, or no breathing. Hyperapnea is a faster breathing. Hyperventilation is a rapid breathing with hypocarbia. So the breathlessness could be sudden in onset and can be seen occurring in several days, and could be a gradual onset. Sudden onset is asthma, pulmonary edema, pneumonia, pulmonary embolism, which occurs in several days, includes COPD, pneumonia, bronchial obstruction by tumor, superior vena cava obstruction. Gradual onset occurs in the cardiac disease and anemia, pleural effusion, primary, secondary lung carcinoma, and ascites. So basically it's an accumulation of the fluid which happens in pleural effusion and ascites, which compress the lung and impair the ventilation. So when somebody needs to assess, then listen and observe, and what does it mean for the patient, and what is the onset like, and if there is any triggers, so that can tell after blood transfusion, or after fluid infusion, or after inhalation of something which could signify asthma, and during some activity, position, at rest, and what is the pattern of breathing, color, respiratory rate, is the patient anxious, what are the oxygen sessions. So one has to manage the reversible causes optimally according to the patient wishes, and consider active treatment of infection, pleural effusion, pneumothorax, PE, airway obstruction, and anemia and CCF. Positioning is important in the patient. Make a patient in a relaxing posture, and energy conservation, controlled breathing technique, physiotherapy, loose clothing, and mouth care. Opioids can sometimes be used which help in relief asthma. Likely the benzodiazepines can be given, but should be given cautiously in relation to underlying lung disease, as they can sometimes cause aggravate difficulty in breathing as well. Oxygen therapy only when appropriate. Mix evidence, check saturation, and steroids can be given in COPD and asthma. Bronchodilators, antibiotics, nebulized saline is also very effective in loosening the secretion, and if the patient is anemic, then blood transfusion can help. Repositioning of the patient by tilting side to side, tipping the bed, head up. Management of mouth care is important. Discreet management of the oral secretion with mouth care, suction, reassurance of the family, and reduce the oral fluid intake to the risk of aspiration. Secretions can be treated by giving buscopans, and follow the local therapy, glycopyrrolate, and consider the heart rate when giving glycopyrrolate, and hyoscine butyl bromide is the drug of choice for secretions. So degree of urgency: is the patient going to live long enough to give the history, or one has to intervene and try to make diagnosis quickly? An assessment of the patient involves: is the patient actively trying to breathe? Look for mechanical obstruction. And is the patient hypoxic? If yes, increase the FiO2. Is the patient not able to breathe adequately? If no, supplement the respiratory effort. Locate the problem: causes of air hunger, mechanical, metabolic, cerebral, or psychological. One has to correct it. After the correct diagnosis is made, the treatment is relatively simple. One has to see all the diagnosis and evaluate the threat to life, and when and how to intervene, and understand the tools, understand the available interventions, and know when to escalate the problem and get the help from the seniors or people who have more experience in respiratory therapy. One has to assess that: can the chest wall support breathing? Are there barriers preventing any air getting through the air to blood? Are there any metabolic reasons to increase the respiratory rate? Is enough blood or good quality going around? And if not, assess the circulation. So the purpose of respiration is gas exchange, to assess the balancing blood pH, lesser the extent of temperature regulation, cooling the body, and cellular respiration and organizing of respiration. So carbon monoxide, even in a small amounts, can bind with the hemoglobin and cause a competitive binding. Methemoglobinemia occasionally causes dyspnea, usually just tachypnea. And helium instead of nitrogen is an inert gas. Helium molecules are smaller than nitrogen and cause less turbulent flow. Noxious toxic gases inhalation can affect the breathing. Allergens and irritants can also cause bronchospasm. Mechanical airway obstruction could be external or could be internal: growths, encroachment, and internal substances. External could be gagging, strangulation, smoothing. Internal could be food bolus. Other mechanical airway obstruction: peanuts, beets, which are commonly seen in children. Internal growth, tumor, infection, and abscesses. Encroachment of the airway and internal substance like pus, blood, mucus, clots, and transudates. So muscular and chest wall systems like diaphragm, diaphragmatic paralysis, weakness of the diaphragm, chest wall weakness, accessory muscles such as supraclavicular and neck muscle weakness, myasthenia, paralysis of the muscular causes increased muscle tension. These all these leads to breathlessness. Air into blood interface, mechanical filling of the alveoli, lack of surfactant, and alveoli collapse with exhalation. Abnormalities: thickening of alveolar membrane, interstitium, tissues between the alveolus and the capillary endothelium, and the blood, is the blood flow enough or flowing well? So one has to calculate the shunt. So the causes could be psychogenic, hypoxic, metabolic, pulmonary, cardiogenic, hematologic, or any other. So one has to evaluate by taking history, physical examination, and perform the formal studies. Pulmonary function testing, ABG, blood, chest X-ray, ECG, CT, and ultrasound are the common tests um, used in the diagnosis. Also take the history of cough, for how long the patient is having cough. Is it dry, productive, vomiting? When was the vomiting? Temporal relationship and circadian variations. Is it a good or bad cough? Central or peripheral triggers. Air travels in excess of 150 kilometers per second during a cough and can denude the respiratory epithelium, expose the basal membrane, and stimulate the future antigenic response. So coughing till you vomit is a bronchospasm until proven otherwise, and consider cardiac causes as well. Vomiting, then coughing, then patient then need to think of aspiration. Vital signs: normal or stable. How do they change over the time? And they can tell you a lot, which we'll be discussing in subsequent slides. The meaning of each value depends on its content. A slow respiratory rate is a bad in a bad asthmatic may mean the patient is about to die, and a slow respiratory rate in an anxious bystander may he is getting better. Respiratory rate, do it yourself, and uh, heart rate, BP, and respiratory rate all need to be monitored in the assessment of asthma and breathlessness. Pulse oximetry, one has to understand the dangerous levels in terms of pH and CO2 and O2 levels, and then examine the patient and see the progression of the patient after the respiratory therapy or further management. There can be various combination: high respiratory rate, heart rate and BP, low respiratory rate, heart rate and BP, and high respiratory rate and heart rate with a low blood pressure. So one has to make the differentials accordingly. In the examination, see the accessory muscles, facial expression, chest wall, lung, heart, abdomen and extremities, and especially look for a central and peripheral cyanosis. Observation of the patient, auscultation and palpation, scratch test, habitus, look for edema, muscle wasting, and a lot more findings can be seen. So pathophysiology, one has to understand the role of chemoreceptors, mechanoreceptors, lung receptors. Three components then contribute to dyspnea and afferent signals, afferent central information processing, and brain compares these afferent and efferent signals, and a mismatch result in sensation of dyspnea. Afferent neurons go from the chemoreceptors, carotid bodies, juxtacapillary receptors, chest wall and its muscle, spindle sense, and lung parenchymal tissues. And motor neuron, respiratory muscles, diaphragm, intercostal abdominal muscles, and accessory muscles. Central processing could be objective data, subjective data, psychiatric and diagnostic exclusion. The dyspnea can be graded according to numbers: 0 no dyspnea, number 1 only when walking, number 2 slow level and stops after 15 minutes, 3 stops 15 minutes of walking on a level, and 4 minimal activities such as getting dressed, and there's 5 is too dyspneic to leave the house. 4 general categories could be cardiac, pulmonary, mixed cardiac, pulmonary, and non-cardiac, non-pulmonary. Common specific disease entities could be asthma, pneumonia, pleural effusions, pneumothorax, interstitial lung disease, COPD, psychogenic, pericardial effusion, cardiac ischemia, CHF, dysrhythmia, mechanical obstruction, and anemia. Blood tests could lead to, which are used commonly, are ABGs, D-dimers, BNP, basic metabolic panel, cardiac enzyme, and there could be other tests depending on the patient situation. Chest radiography could be insufficient by itself, and one has to look for important signs according to the patient's clinical examination. Look for pneumothorax, aortic dissection, pneumonia, pleural effusion, subsegmental atelectasis, pulmonary infiltrates, and or elevate hemidiaphragm. ECG, lots of clues as to cause of dyspnea. Look for pericarditis, S1, Q3 and T3, and right axis deviation on the ECG, and myocardial infarction, ST segment elevation, and there could be global T-wave inversion in the pericarditis, and S1, Q3 and T3 in pulmonary embolism, and new onset of atrial fibrillation or right heart strain. Arterial blood gases must interpret in context. Complete ABG includes lactate, and venous blood gases can sometimes be helpful as Arterial blood gases have three components: pH, PCO2, and O2. pH changes because both metabolic and respiratory causes. Each tries to compensate for abnormalities in other. pH should be 7.3 if lower, acidotic; if higher, basic. PCO2 should be 40 plus minus if lower, breathing is too much; if higher, not breathing enough. CO2 and bicarbonate is the end product of oxidative metabolism. O2 percentage plus oximetry is equal to saturation and should be 85 to 100 if lower, hypoxic; if higher than 100, getting more than 21% over the breathing seriously. PO2 is a measure of oxygen carriage, and the oxygen carrying capacity is function of amount of the carrier and carrier saturation. Respiration, acidosis and alkalosis. Low pH is acidosis, low pH, high CO2 is respiratory acidosis; low pH, low CO2 is metabolic acidosis; high pH is alkalosis; high pH with low CO2 is respiratory alkalosis; and high pH with high CO2 is metabolic alkalosis. Ventilation, perfusion, scanning combined with the clinical suspicion, sensitivity of 85 to 90%. Positive predictive value depends on the clinical suspicion and more radiation than CTPE study. There are two kinds of rapid helical without contrast CT scan and usual speed with contrast. CT is more rapid, safe, detects more potential causes of dyspnea, better accuracy than VQ. Helical CT scanning, no contrast is needed. Regular PE protocols requires a normal creatinine or GFR, and always consider metformin. Ultrasonography and echocardiography. Trans-esophageal echocardiogram is 90% sensitive for large clot, very specific, and transthoracic echocardiogram, aortic dissection, cardiac tamponade, and acute valvular lesion can be ruled out. Asthma, pneumonia, acute pulmonary edema, pulmonary embolism, emphysema, pneumohemothorax, carbon monoxide, and cyanide poisoning should be considered when managing these patients. Asthma is reversible bronchial constriction, air block between the large airways to the alveoli. Alveoli may collapse. Treatment: open the airways, prevent stacking, and keep oxygen high enough to keep the patient's brain alive, and consider steroid permissive hypercarbia. Pulmonary edema, basic problem: the heart stretches so far it cannot contract well, falls off Frank-Starling curve, cardiac oxygen demand exceeds the availability, air can't cross the air-blood interface, and fluid seeps from the blood into the alveoli. Surfactant gets diluted and caused by the cardiac and vascular derangement and vicious cycle. Symptoms include sudden onset of respiratory distress, rales, rhonchi, foamy sputum, sometimes blood stains, blood pressure is high, vasoconstriction, and if the onset between 4 p.m. and 8 p.m., likely to be associated with acute MI. Treatment: increase with airway pressure to force the fluid back into the vascular system. Increase FiO2, dilate the blood pressure, and reduce the systemic blood pressure, which reduces the work of the heart and reduces the oxygen demand. Get excess fluid off the kidney if working via bleeding, bloodletting, and sequester the fluid. Tourniquet. Diabetic ketoacidosis, tachypnea often without air hunger, metabolic derangements, blood is too acidic, respiratory system tries to compensate, get overwhelmed. Pneumohemothorax, stuff gets between inside the chest wall and lung, air cannot get in well, and blood can't go round and round well enough. Treatment: mechanically remove the stuff that keeps the lung collapsed, needle with flutter valve and chest tube, intubation, and if there is a flap. Pneumonia, infection in the lower airway, consolidation, fluid alveoli, often only one part of the lung is involved and generally sick. Upper, middle, and lower airways are clogged by the mucus and often tenacious, and fever increases, metabolic demand for oxygen, treatment, antibiotics if bacterial, thin mucus, mechanical ventilation if needed. Pulmonary embolism, a blood clot in the pulmonary circulation, often from the systemic venous circulation block. Blood can't go around and round, so there is a lack of oxygen in circulating blood. Diagnosis: hypoxemia, tachycardia, tachypnea, sometimes chest pain. Treatment: anticoagulation and O2 supplementation. CO2 usually normal. Emphysema, not enough lung tissues, that is paucity of the blood interface. Optimize all functioning tissue, and the treatment is lung transplantation. CO2 poisoning, competitive inhibition of the oxygen binding at hemoglobin site. Treatment: overwhelm with the CO and 100% with O2. If not enough, use hyperbaric oxygen. Cyanide poisoning, mechanism of intubation and O2 utilization at the cellular level, and there can be plenty of O2 in air and in blood, but the cells can't use it. Treatment is inactivate the cyanide using BAL, and the time is essence. In summary, dyspnea is subjective. Think systematically, multiple causes, multiple tools to diagnose the problem. When you can't breathe, not much else matter. So this is very important to treat. I hope this summarized the important topic. Thank you.